All right. Hello, everyone. It's great to see you today. We are into our 4th week of our introduction to palliative care in refugee camps in Kenya. And we're really quite excited that you're with us. We have done our sessions on introduction as well as pain and symptom management. And now we'll be focusing on communication in palliative care, which will focus on culturally sensitive ways to support people during their illness, as well as including some content on grief and loss. And we're really excited to be having Vilma, who is one of our faculty members, as well as Sarah. They both are actually from Canada. Sarah is currently living in Kenya and is posted here for the last 1.5 years. And Vilma is based in Canada and currently works with a community hospice. I'm really excited about today. We are hoping that you will learn some new skills in communication and be able to identify some culturally sensitive ways to do that for your patients, including some techniques on active listening, as well as understanding a model called spikes. So we're really excited that you're here with us today. This is our Project ECHO course in collaboration with UNHCR, PalChase, as well as Africa Palliative Care Association. And we have several of our faculty members on the call with us today. If you see on the participant's name, you'll see a hashtag. If you wanted to reach out to any of the faculty members, you can privately message them. Vilma is with us, Sarah, as well as Dr. Zippy from Kenya, which is great. And I'm seeing a few things in the chat. Osman, you're having difficulty hearing. You may want to exit and join again. Sometimes it asks you how you would like to listen. Oh, you just directly messaged me. Yeah, so maybe you should exit the Zoom call and then try again. And then I think there's an option to listen via Wi-Fi or data. So you should choose that one. But yes, we are into our 4th week and we're really excited that you're with us. Just a reminder, if you have the chance to put your video on, we'd love to see you. And if you have any questions, you can put them into the chat. Just remain muted throughout our teaching time. And we will have time for discussion, as well as we'll be going through a case talking about communication. And yeah, we're really excited that you're with us. This program is also connecting healthcare workers that currently work with MSF in Kenya, as well as IRC and Kenya Red Cross. So we're really excited you're here, and we're nearly halfway through the short course, which is exciting. I will hand it over to Vilma and Sarah. If you can put your name in the chat and just let us know where you are working, it would be really great to be able to remember you all as our participants. And thanks so much, everyone. If you have any questions, just again, also put that into the chat. All right, Vilma, welcome.
Hello, everyone. And just let me figure the configuration here. Okay, let's see. And there. Okay, thanks for the introduction, Erin. And the topic for today, well, first of all, I'm Vilma, and I do work in a community hospice here in Canada, near the Toronto area. And my experience, I have a lot of experience with grief and palliative care, and I'm hoping that you learn a lot today. So thank you for being here. And let me know if you have any issues with screen or anything, okay? And if you have any questions throughout the presentation, please just write them in the chat and we'll be checking that. So the objectives for today, hopefully, at the end of the session, you will be able to apply a culturally sensitive and grief-aware approach to all your interactions. And I really want you to think about this. We're going to talk about communication in palliative care, of course, but this is something that we can apply to all our lives, right? We're always encountering people in our lives, and we don't know what's happening in their lives, what they're going through, and what their backgrounds are. So We're going to be talking about all that. So keep that in mind as we go through the presentation. We're going to recognize that grief is a unique component of the patient and the family's journey. And we're going to learn and practice humble curiosity and active listening techniques. And at the end, and Sarah will guide you through this, we're going to review a case following the spikes model to deliver values. Any questions? Remember, put them in the chat. So, why we're talking about communication? Because in palliative care, especially, it is never easy, as we often have to discuss hard topics. But I want you to remember, as Maya Angelou said, there is no greater agony than bearing an untold story inside you. We want people to share the story. We want to get to know them. So we're going to learn about effective communication and what that is and how to put that into practice. So starting with the concept, effective communication is a core clinical skill and the foundation to excellent and successful patient care. And as I said before, we can't really know what's going on in people's lives, right? So we have to be open to listening and practice this communication skill. When we practice communication, we have to make sure that we are exchanging ideas, thoughts, opinions, knowledge, data. And as you see, it is an exchange. It's not just one way to the other, right? It's both ways. We have to make sure that the message is received and that it's understood. We have to make sure that it's clear, that we have achieved a purpose. And when we communicate effectively, both people or the person, the family, whoever we're talking to, the sender, which in this case will be us, the healthcare providers, and the receiver, which will be the patient and or the families, are satisfied. So both of us have to be satisfied. So what are the components of effective communication? And we're going to go through them, right? And remember, if you have any questions, just put them on the chat. We're going to have discussion time for this. Humble curiosity, we're going to talk about that. First, we're going to talk about empathy. And what is empathy? These are the two things that we have to bring into our conversation. When we're empathetic, we are able to understand and share the feelings of another person. Not just listen to them, not just be sympathetic. And we want to learn more about what they're going. So we have to understand, and how do we do this? With humble curiosity. What can I learn from them? Some characteristics about empathy is when we show it, we are genuinely curious about what's going on in other people's lives. We really want to learn about them. We are good listeners. And we'll talk about some skills for being a good listener, but we have to listen. We validate the person's feelings. We are aware that they're experiencing this, and we validate it. We try to imagine ourselves in the same situation, or if it's not the same situation, something similar. We have to think about a time in our own lives where we experienced something similar that was maybe as painful, right? If we're working with refugees, which most of you are, we have to remember that everything that they're going through links to all their experiences. So maybe we can reflect on that and think about something that happened to us that we can bring to the table. We have to be present. This means we are here with you. I'm here right now, listening to you, being mindful, being, like thinking about the million things that we have to do outside. Be authentic, be you, right? And remember, we come in with this hat of healthcare providers, but we are people. We're both people. And we have our own experiences. And show that. Don't be afraid of even being vulnerable sometimes. Be supportive, right? Say things that make them feel better. Show them that you're there for them, that you will walk with them. Be yourself and share. Share means when we're showing empathy, we might even say, I get it. I had a similar experience. And and maybe just share a little bit, right? It's not, the goal is not to switch it around and now, they're the ones that are providing support to you, but being there and sharing that we're humans too and being open to that. Another component of effective communication is being aware of diversity. So when we are with someone, they come as a whole person. So when we're sharing information with them, we have to keep in mind that the patient's life's experiences will determine how they understand and process the situation, right? Not everybody is the same. There's no 3-step recipes that we can follow on how to communicate with people. We have to remember that they are their own person and they bring everything to the table. Their level of education, we have to speak in a language that they can understand. Their sexuality, gender, the age, right? It's not the same when we are talking to a child and we're talking to a teenager than when we're talking to an adult. It's not the same either if the person who is ill is the child than if it is the grandmother who is 98, right? It's not the same. Painful, yes. Hard, yes, but it's different. And also their ability, right? We have to think about what they can access, what they have had access to. The language, is that a barrier? How do I talk, right? If it's the same language, are they going to understand it? It's their second language, right? All of this comes into place. The culture, the ethnicity, race. And why is this so important? Because my beliefs and what I'm comfortable with might not be the same as what they are used to, what they have learned, right? So we have to think about that when we're communicating. Our body language is another component of effective communication. Why? Because everything that we do is saying something, not just our words. Our facial expressions, our body posture, our gestures. If we touch them, the way we use the space, and we're going to talk more about this down the road. But we have to remember, and this has been proven, is that only 7% of the message is verbally communicated by words. So what we're saying is just a tiny bit of the message. The rest, 93%, is non-verbal communication. How we say it, 38%, our tone, in what we put emphasis in, all that. In our facial expression, posture, gestures are the rest, the 55% of the nonverbal communication. So keep this in mind when you're talking, right? It's not just what we say, how we say it. And when we ask patients and family what's important for them when we're communicating as healthcare providers with them, is that we're honest, that we're empathetic. Remember what we said about empathy, right? That's at the top. That we provide adequate information. And this means that it's clear and understandable. If we're saying all this medical language, they might say they got it because they don't want to, maybe they don't want to look like, they don't understand or ignorant or I don't know what, right? So it's up to us to share in a way that it is clear and understandable. That we respond to their concerns, that we pay attention to their emotions, that we discuss what can be done with realistic goals. So be honest, right? And we're going to talk more about that. And that they're included in the decision-making process, that we're not just there prescribing. So this is what you should be doing, right? It's what's important for you. Maintain their dignity and their autonomy in the process. Another component, right? And this is so important because the only way we're going to achieve everything that we've talked about so far is if we're self-aware. Who am I? What do I bring to the table? Because what I am as an individual, including my personality, actions, values, beliefs, emotions, thoughts, everything will determine how I present. My biases, my judgments, my reactions, all of them. I have to be aware of it in order to even like change, control it in what I say, what I do, how I present, how I respond. All that will depend on how aware I am of myself. And I always say, judgment awareness is a skill. We hear often the term non-judgmental, right? But that is not possible. We're all human beings and we're always judging because that's how we survive. We always think about, is this safe? And what am I going to be doing? What would I do if this situation happened? We're always making judgments. But if we're aware of them, we can address them in an appropriate way, right? So be aware. And if something triggers you, or if you're thinking about a bias maybe, or they're not doing what you think they should be doing, or the way that they're responding is not how you will respond, just think about it. Don't say it. Don't share that. And again, another quote by Maya Angelou, which I love, is that people will forget what you said, what you did, but they will never forget how you made them feel. So, you might judge, you might do things in a way that they don't approve, and they might not even remember that. But make them feel comfortable, make them feel like you really care about them. And that's what they will remember. So active listening, and we said this is a huge one. And these are just 6 very clear steps on how to be present and show that you're actively listening. So practice the skills. The first one is pay attention. Be there and really pay attention. Do not interrupt. And we're tempted so many times, right? And be comfortable with silence, because when people are silent, usually what they're doing is they're processing, right? Especially if we're saying something that is hard for them to hear. They're trying to reflect on that and maybe, think about how they will respond, or maybe they want to share something that is very hard for them, and they're taking a moment to get the courage to share that. So pay attention, don't interrupt, be comfortable with silence, withhold your judgments. And like I said before, right? Be aware, be judgment aware, reflect. When they're talking to you, think about what they're saying. Not to give answers, but to see how you can support them better. Clarify if you have questions. You can say, for example, so what I'm hearing you say is this. Am I correct? Did I get it right? Summarize. So at the end of the conversation, say, so in this conversation, we talked about this, this, and this, and this, right? And always ask for clarification if that was correct. And then at the end, share what are the next steps? What you're going to be doing, what is expected from them. So make a plan. And always remember the 80-20 rule. As healthcare providers, we have to listen 80% of the time and only talk 20% of the time. And the patients have more time to share. That's the only way we're going to get to know them. Now, what are some difficulties in effective communication? The first one, or the one that we're going to focus on, because there might be many, but it's breaking bad news. In our roles as palliative care healthcare providers, we're going to be sharing bad news, right? And what does this mean? A bad news is any information that is likely to alter drastically a patient's view of his or her future. So anything that might disrupt their assumptive world, and this is a term that we use because we all make assumptions of our world, right? And we can think about this even with COVID, right? How our assumptive world was shattered and how we all experience some kind of drastically alteration of our lives. So think about that, because we all can relate to that. And in other words, and this is how we address it, is that the patients and the family will grieve. So this might be a term that you're not used to listen to in this context, but we're going to talk a little bit more about it. So what is grief and why do we talk about grief? Why do we grieve and why it's important to learn about this? And this is a very simple explanation. Of course, it is more complicated than that. But as humans, when we love something or someone, and it can be real, ideal, it can be absent, it can be, for example, right? I love my life. I love what I do. I love my family. I love my role. I love my status. I love all of this. And it can be a person, so something, we can see it, we can touch it, it's real. It can be ideal, like if in a, as refugees, and I can tell you this because my own personal experience is that idea of who I was, who I am right now, who I want to be, all these things, we're attached to them. We are, as humans, we are. That's just how we are designed. And it can be tangible or intangible. So tangible, like my body, right? I love my body. And if I lose a part of that, even like, an amputation or an ability or anything that has to do with that, or it can be intangible, like an idea. I have this idea of myself. I'm an able person who can do certain things. And then if I can't do them, then I lose that. So all of this experience from loving, attachments, and loss is what brings grief to our life. So it is an experience, really, because we all go through it and we all respond to it differently too. And, because we're all different. So we do have to remember that grief is a normal and natural experience, and it's a part of the whole journey. And also remember that it is not a mental illness and it's not something to be fixed. And I usually say, because I do work a lot on grief and loss and in bereavement side as well, the only way that we could fix it is if we could bring back what was lost. And we're not able to do that. So there is no fixing. We just need to be there and accept it as a normal experience and be supportive and present. That's what we can do. And when we talk about grief, we're usually talking about anticipatory grief when we're giving this news or when we're dealing with an illness or the trajectory of, treatment and all that from beginning to end. So the whole umbrella, and even after someone has died. But anticipatory grief refers to the grief that occurs before an impending loss. So we know, the families know, I'm going to die. My person is going to die. So we're anticipating that loss. And it doesn't necessarily have, has to do with the death, but when someone has a threatening illness, right, how things are going to change. So there's going to be all these losses along the way. The loss of control. Now I can't control this. It's just happening. It's happening, right? What am I going to do with it? Physically, loss of appetite, changes in the daily routine. I used to be able to work. Now I can't work. What is going to happen? Loss of health, loss of bodily functions as the illness progresses, right? And this is huge for people because it impacts their dignity in their idea of who they are, their identity. I'm losing parts of myself, my sense of belonging, my assumptive world. Like, if I am the most responsible person in this family, the main provider, what's going to happen? And all these questions. So there's a lot of losses. And the changes in roles and responsibilities, the caregivers, right? And I was the main caregiver. Now I have to accept people caring for me. So that is huge for people. And there are going to be many changes as the illness progresses. So there's going to be more news, more grief. So how are we going to address that? And it is tricky, right? Breaking bad news, because if we do it badly, the patients or family members may never forgive us. And if we do it well, they may never forget us. So remember that. Now, as Erin said, we're going to use the acronym SPIKES for breaking the news. And Sarah is going to talk more about this when she presents the case. And hopefully you got a chance to look at the video that Erin sent in advance because it has some information about this. But right now, keep this in mind and everything that I said, and we're gonna have some discussion time. So I'm gonna, I don't know, Erin, do we have questions in the chat? Do people wanna ask some questions?
Yeah, let's give some time for questions. You can, I guess you could stop sharing and we could bring back the PowerPoint after. Thank you so much, Vilma, for sharing about communication and really bringing in very important aspects of grief. I'm wondering if anyone in the group has a question. The situations that Vilma had been speaking about may be more unspoken in your situations where you work, because talking about grief and loss might be difficult because of the trauma that so many of your patients and yourselves have experienced working in the refugee camp. But does anyone have a question or a thought or a comment? Welcome to raise your hand or unmute and put your video on.
And I want to say something, Erin, and I know that especially with grief and loss, right? It is a topic that is not usually discussed in most cultures. It can even be a taboo, right? Like, you know, if you talk about it, then you're acknowledging that it is happening, right? We tend to, when we get news like this, it is very common to be in denial and just say, no, right? Like this is not happening, and maintain the hope, which is something that we do encourage, right? But with the hope, and it goes hand in hand with this that we have, what can we still do? So the quality of our lives, the new normal, in be, you know, how do we make it meaningful, still maintain, or, you know, the dignity and enjoy life? Because at least, you know, for us in hospice, the philosophy is you're not dying. I mean, yes, you are, but you're living, right? You're not dead yet. You still have your life. So what are you going to do with this life that you have? But just saying some of these words can be hard in thinking about culture too, right? Some people might think that you're predicting or accelerating death if you talk about it, right? Or so there's so many components to it. Yeah. So if anyone has any questions, yeah, or even later, I know that is a lot to process, but I have a lot of resources, so you can always do that. Yeah.
Gabrielle, I see from the chat you're one of the psychiatrists with MSF. We'd love to hear your perspective on your practice and how you support your patients.
Yeah, hi. Thank you, Erin. Just I was actually typing my question in, but thank you for the chance. Yeah, I had a question in regards to communication, especially when you talk about when you're giving out information or breaking bad news, or when you're doing the humble inquiry regarding, you know, a case. Some of us are working in situations where we are working with translators. And so once you introduce that person, your facial expression, okay, your nonverbal communication becomes an issue, because you may put the nonverbal communication, but your translator lacks this. So other than training, because most of our incentives are training in communication, are there other ways or means we can use during communication to ensure that the patient is able to understand our feelings, that our empathy is there, without literally, you know, undergoing the length of or the breakdown of non-verbal communication between me, the translator, and the patient? Thank you.
Yeah, I think you bring up a really good point. And it might be something that we do need to get some more information on. I think the use of medical translators is really important. I think one way that you would be able to ensure that the medical translator also is showing empathy is that if they are seen as part of the medical team. I'm not sure how it is in your practice, but I think using the medical translator, sharing a bit of information before you head into a meeting, especially if you were delivering bad news, I think could probably go a long way. I'm not sure if there are stipulations on what the medical translator knows about the case, but I think that if it was possible for you to have a short meeting with the translator before you go into these very complex communication situations, they will be more ready to show the nonverbal and empathize because it won't be also in that sense a shock to them as they're trying to share this information. Gabriel, are you allowed to meet with the translator ahead of time, and are they seen as like someone as part of the medical team?
Yes, we do. Yes, we do.
Okay.
We make sure before a session we introduce them as part of the medical team.
Okay.
And we also try and give them a title that she's either an auxiliary mental health personnel,
Oh, nice.
or she's either an adult ward personnel, and that. Yeah.
Yeah, I think yeah, it's really good, and I'd love to be able to add some content in our communication training in the future related to translators, especially when, I mean, I think it's different when you're translating. Maybe there's a change in medication, or the patient is, I mean, I guess in healthcare, most of the things you're communicating is sensitive, but especially when you're sharing prognosis or if someone is declining, oftentimes we find in palliative care, we do have to talk about very difficult things. So I think having that translator, or if there's one person that seems to be very empathetic in how they translate and using their nonverbal, having them kind of as a point person that feels comfortable to do palliative care translation, maybe something that's helpful.
Can
Vilma?
I add something, Erin? Yeah, I
Yeah.
wanted to say something about that. And because, I mean, it's not the same as at least for me, right? To be given a diagnosis, but where we are here, it's very diverse. So there's people who don't speak English, right? So that we have to go and visit. So one thing that has worked for me when I'm visiting someone, maybe the parents don't speak English, but the kids do. So they're the ones translating, right? Or it could be an official translator, like a hired translator. Because of that when we're saying something, it's our body language, right? So even if we are saying it in a different language, when we're talking to the patient, look at them, right? Instead of looking at the translator, right? In that 93% is gonna be transmitted that way. So at least I try to do that, even if I have a translator, because I'm showing that empathy, and that is being communicated even if they don't get the words, right? And even when the translator is speaking, continue to be supportive and not looking at the translator, but looking at the patient, right? And showing them that you're there for them, that you're getting this with them, right? Yeah, it is complicated. But one other thing that we do is that we have trained volunteers who provide peer support. So someone who has a similar experience, and we try to match people who speak the same language too. So when they, if I don't have anybody else to come with me, I will bring the volunteer with me, and they also can have a conversation about in their own language about their experience because they both get it, right? So I guess that's another option. But yeah, we should probably have more ideas around this because it is an important topic. Sarah, do you have any ideas? Any other ideas?
No, I was just going to share something very similar, Vilma, just making sure that you take time to set the room up appropriately, that you're sitting the way that you're setting up the room so that you're all facing one another. Maybe it's in a circle formation, that you're taking the time to make eye contact with the patient, that your gestures are towards the patient, your tone of voice, the way that you're delivering the information is heard, just like Vilma said, and is picked up on. And even if in the translation some of that is missed, I'm sure you're so used to like clarifying the information. Do they understand this? Can you have them repeat it back? And then, so it takes a few more steps, but I do think that it is still possible to communicate that empathy, that even if it's through a third party. And I think it's exactly like Vilma said, just you making that eye contact, the gestures are directed towards that person, all of those things.
Thank you. Thanks.
Yeah. And
Yeah.
Gabriel, do you find that the person that is translating is from the refugee community, or are they from the host community?
Yeah, our translators are from the refugee community and some
Okay.
from the host community who are also
Okay.
Somali. Yeah, so
Okay.
they speak the same language.
Yeah, I feel like with translation, I don't fully know it, but I would love to maybe meet some of your translators. I think obviously that's a very high calling to be a translator, right? Because you're not necessarily the person that has come up with the plan, but you really need to be able to share the information the way it's been said. And especially when we talk about communication, it's so difficult, especially in palliative care, because it's painful, it's sad for the healthcare providers. And I think, yeah, we would love, I don't know if anyone in this group is a translator. I think not, but maybe that's something that we can think about in the future, Gabriel. I can maybe side chat you during the week, and we can find out maybe a few things we could do to support them as well. Because I think it's the secondary trauma that we as healthcare workers also face, but we do have a bit of the medical knowledge. Well, we have medical knowledge to support us in that. But I wonder how translators cope with that as well. Really good question. Does anybody else have any comments or thoughts? Barbara, I know you're one of the leaders on your team. How do you and your team deal with communication? Dr. Barbara, are you around? We could probably go on to the case. Vilma and I obviously will be here. So if you have any questions, you can put them in the chat. Oh, hey, Barbara.
Hey, sorry, yeah, I was struggling to find the unmute button.
Oh, no problem.
Yeah, I'm really brought that up because it's really the same challenge and the same question that I had as I was listening to Vilma is when you're not speaking the same language and you can't understand each other, how do you really use a third party to show empathy and to, it's kind of hard to translate emotions to another person. So it's the same situation. We don't have, I think we have very few areas where we have actual translators. Most of the time, we just use our other staff who are refugees also.
Yeah.
And come from the refugee community. So they're the ones that we use because they're already working within the clinical areas and we have immediate access to them. And yeah, I think it'll take some kind of practice and in being mindful and also translating the training that we're getting here to them so that we can effectively communicate and give the patients the best. So thanks, Gabriel, for the question, and to Erin and Vilma for the responses, and Sarah.
Yeah, maybe what we can do as kind of a follow-up maybe Vilma, Sarah, and I could even put together a few sheets for medical translators, because I'm sure medical translators are not, yeah, of course, they're translating for a variety of reasons. So maybe we could do one with a focus on palliative care or suffering or something like that. Or when you have to translate for prognosis and things like that, that might be a really helpful tool that they could use. We can definitely look into that.
Yeah. Okay.
Mhm.
Thank you.
Okay, yeah, let's head on to the case. We have about 15 or 20 minutes, and this is a really important topic in case, and I think we're going to learn as we discuss. So go ahead, Sarah. Thanks so much.
Okay, hi. So my name is Sarah, and I'm just going to continue on with the rest of this presentation here. So we're going to use the spikes model to sort of work through this case study. And this is a really great tool because it's very simple. It's really easy to apply to any situation where you're having to relay really important, sensitive information, really difficult information. And what's great about it too is that it's flexible. So you can use it in a way that suits you, that works for you. You can adapt it in a way that works for however you need to present information once you're familiar with the tool. So the case study that we're going to use today is one that we thought of, and we thought of it based on some of the information that you have shared with us over the past few weeks about some of the challenges that you face in some of the camps, and with some of the patients and their illness trajectory and why palliative care is introduced. So I'm hoping that this case is a little bit familiar. And as we go through it, maybe you can think of examples of cases that you've had, things that have gone really well, things that have not gone so well. And if you can share them, we can all learn together because, yeah, there's definitely models to use to relay this kind of information, but obviously every case is different for its own ways. And so the more we hear about how people break this kind of bad news, the more we can learn and improve the ways that we do it. So Samira is a 50-year-old female who is showing symptoms that are conducive with a diagnosis of invasive breast cancer. She has 2 visible tumors in her right breast, and given all the evidence available, the medical team has determined that it is highly probable Samira has metastatic breast cancer. An aggressive course of treatment is necessary, but this treatment is not accessible. Without treatment, her cancer is terminal and will continue to progress, resulting in a high symptom burden. Next slide. Samira has no husband. She has 3 children and several grandchildren. She is the matriarch of the family, and her children rely on her both financially and emotionally. Samira and her children are aware that she is ill, but they still are unaware that she has cancer. Samira's children have different views on how to discuss a potential diagnosis. 2 of her children would want to tell their mother of that diagnosis, while the other child would not want to share the diagnosis, fearing it might worsen the outcome for their mother. What we know is that this is an advanced metastatic cancer with no cure, and that the patient must be told in a compassionate way. And with our understanding that once Samira becomes aware of her diagnosis, she expresses fear that the cancer will become more painful, and she is afraid of what will happen to her children when she is gone and who will take care of them. So let's start to work through this, how we would break this news to Samira. So the first part of Spikes is the setup, and the setup is the physical setup of the room. This means, how are you setting up the room to make sure that it's private? What are some of the things you want to consider? If you don't have privacy, can you draw curtains? Can you make sure that the space is as quiet as possible, even though you may be working in a place that is very noisy, and very, very busy? How can you make it a very calm, peaceful place where privacy is respected? Do you invite family members or do you not invite family members? I think something to consider is, before you have this meeting with Samira, give the patient a little bit of information on what the meeting will be around, so that they are prepared for a meeting that's going to be discussing their illness. Maybe encourage them to bring a family member if they feel that family member is trustworthy, is someone that they have confidence in, is a support system for them. A family member or a friend or a community member can be really important to take notes when you're sharing really difficult news, so that there is some kind of history being taken. Sometimes when we receive really bad news, we know that we blank out. We can't really make sense of the information that we have. Is it appropriate to have a counselor present? So these are sort of the things that you want to consider when you're setting up a space. The other things you want to consider are your own personal setup. So how are you coming into this conversation? Are you rushing in from another interaction with the patient? Are you, coming in with an energy that is negative, or you're stressed, or your mind is somewhere else? In any way that you can, take a moment before you enter into a conversation like this to take a few deep breaths, to maybe transition from whatever you were doing into the current conversation that you're having. We all know as healthcare providers that we are so busy and we are always on the move, but it's really important to just find a moment for yourself so that you can transition, so that you can be present and calm to deliver this information. Okay. So the next step is, what words would you use to sort of initially begin this conversation with Samira? So something you could ask is, what have the doctors, or what has your medical team told you so far? And what do you understand about what they have told you? What is your current understanding of this illness? Seek information from Samira and listen to what she has to say about her understanding of her illness, how it's affected her so far, what doctors have told her. It gives you an idea of where she's at, what kind of information she has, and how you can proceed then to share this really bad news with her. Invite her into the conversation. I think patients often find that they don't have a lot of autonomy or a lot of choice in how things are given or presented to them, or in their illness progression. And so can you empower the patient to ask them, can I tell you more? Are you comfortable with me telling you more? And if they're not comfortable, can you tease that apart? Can you understand maybe why they aren't comfortable receiving information, and encouraging them to hear out as much as they're comfortable hearing, so that they can then make choices, make plans, things like that. And then the knowledge. So how would you communicate this bad news? What we heard earlier from Vilma, one of the key things that's of high priority to patients is that you are articulate, that you're concise and clear, and that you're honest with your patients. And I think that is really, those are things that are really valued. So even though it's really, really difficult to say, and even though they may react with many different emotions, as clearly and as simply as you can. Maybe you might say something like, unfortunately, I have bad news. The cancer has spread into the lymph nodes and there's no active treatment available. this is cancer and it cannot be fixed. Reassure them that this doesn't mean that they are abandoned, that there's no hope, that even though there's no treatment, there are good options on how to help alleviate symptoms and help you maintain a good quality of life. Oh. And then emotions might come up or are likely to come up. And emotions look differently and manifest differently for every person. Some people feel anger and they get very quiet. Some people feel anger and they get very loud. Some people feel sadness and it appears as though they're angry. So acknowledge the emotions that the patient is feeling. You know, you can say, I can see that you're feeling this way. Is that correct? Are you feeling this way? Tell me more about how you're feeling. It's normal for people to feel that way in your situation. Validate that emotion. Show respect towards the patient. You've shown remarkable courage, or, you have been really brave hearing this information. And then acknowledge that they're not alone in this journey, that you are here to support them, that their family may be here to support them, their community, that whatever it is, the path that they're on, it's not something that they have to walk alone. And then summarize. So do you have any questions? Can you develop a plan of action? This is an opportunity to just sort of, in this first interaction, a patient may not have a ton of follow-up questions for you. They're still processing and absorbing all of this information, but just maybe clarify that they have heard all of the information. Really listen to what they're saying, really listen to what they're repeating to you. Is the messaging clear? Are they receiving what it is that you're telling them? If they have someone taking notes for them, are those notes clear? Do you have a plan of when you're going to follow up again? Does the patient have an opportunity to get in touch with you in a day or two to ask you questions when they've absorbed that information? So just so that they know that there is a follow-up. And wherever possible, what we know is that if you can have the same healthcare provider following up throughout the illness, that does amazing things for a development of trust, of an understanding, of more effective communication. So wherever possible, can you have that consistency in the delivery of care and who is delivering that care? So some of the other things that we can think about or that we can consider in this case, because it could be quite complicated and it could go in many different directions. How could you support sharing this news with her children? What would you say to the child who does not want to share the diagnosis? Do you think you have a responsibility to tell the mother? Knowing about it, and finally, knowing about the diagnosis means you can plan and prepare. So when we know something, we have some kind of control over it. And it doesn't mean that we can control every part of it. It just means that we can plan and prepare for the things that might be coming our way. Knowing that in a few months, this illness may present symptoms of shortness of breath means that we can start to give information on what medications are available for that, when that comes, how to make sure that we're supporting quality of life. So I think some of these things are really important to consider. I'm sure that you all have really, examples of situations where you've had to share really hard information. If you're able to or feel comfortable sharing that, I think we'd all feel that we could benefit from hearing. And yeah, just things that you think would work really well in this case study, or maybe how you would approach it differently. The floor is open to you to discuss. And yeah, thank you.
Thanks, Sarah, for sharing the case. Yes, and let's take the next 5 to 7 minutes just in discussion. So if someone has any comments on the case, I know Annalise is now with us. She's one of our other faculty members working in the DAB. Does anyone have any comments or interest in using this tool when you are breaking bad news?
I just want to say something, Erin. Sorry, and I told Sarah this before when we were talking about this, is that it is really a good reminder on how to come. And I love that Sarah also focused on the setup, not just of the space, but personal setup, and going back to how am I coming to this, right? And being grounded and breathing in the one thing that can happen is that we can be triggered also by their emotions, their response, what they say. So being mindful that we have to look after ourselves too, because this is hard, right? It's not just we're here to support them, but who's there to support us, or how are we going to then debrief and process everything, because it's hard for us as healthcare providers as well, right? So we are good to go to the next interaction without bringing all this with us.
Yeah, actually next week we're going to be talking about self-care, especially in these situations where we also experience kind of secondary trauma as our patients are declining. Here's a really good question from Wendy. What's the best way to communicate and initiate conversations or bad news with younger children or teenagers? Yeah, I can take a first stab at it and then I can pass it to Sarah. Or even if Dr. Zippy, if you're on the call, I think it's very important when we're speaking with children that we include their parents, and we do really need to think about what developmental stage they are at. So oftentimes we use different ways of communicating. We often use play, or we can use books or toys to engage with the child, to help them better understand what's going on with them. And we do try to understand what the child knows already, and then obviously share information that's appropriate for them to know. In different cultures, of course, there are different values on how much a child is involved in their medical situations, and many families that are very nervous to share about what's happening with the child. So we often try to understand the situation from what the child knows already. Just being in an environment, being in a hospital setting, and yes, play is one of the best ways to engage with children when we're trying to understand what they know. And then, of course, it is very important that families are involved, or whoever the primary caregiver is. Teenagers are often able to understand much more than a primary school age child. And I think it is really important as a team to decide how you engage teenagers, because generally as children grow up, I don't know if there's particular ages, but 12 years old, 12 plus, I think these types of children, they understand much more of what's going on. And that's really important. Sarah, do you have any comments on the children? And then there's another question.
Yeah, no, I think that's great, Erin. And I was just going to say I have some great resources too that I can share on talking with children, because it is different, and depending on the developmental stage that they're at, you want to adapt and deliver the information. Like even with teenagers, it's important for them to feel that they can still be, not be different from their peers, and that they can be, continue on in the most normal way possible. So I think all of these different stages are a little bit different, but I'd love to share some resources that we often used when talking to young children at hospice, and sharing some really hard, some bad news with parents and everything like that. And I'll send those to Erin and maybe she can deliver them to the group. And I see Vilma also shared some too. So, but yeah, like Erin said, play and toys and, getting down on the ground and like talking to kids and parents that way, things like that can really help. But there are specific.
Yeah, the next question is, can you break bad news through phone calls? I think that probably 2 or 3 years ago, we would have said no. But the things that we've done now since COVID really have kind of turned what we can and cannot do over the phone. I think if you want to use kind of a gold standard, we would highly, highly recommend that 99% of breaking bad news happens in person. So whoever needs to be, like Sarah said, when you're setting up these meetings, whoever needs to be in the meeting, that's important to the patient, that's important to the family dynamics, the community, it's really important that they come. And if it seems like people are delaying that, or there's many, many excuses, they might not be the right person to be in that conversation, especially if it's urgent. So I would strongly suggest that you do give people some time, maybe a day or two to come in. But if it seems like a patient is declining quickly, or there needs to be a drastic change in their treatment plan or protocol, or their prognosis is very poor, I would definitely recommend that people come into the hospital. And even if you have a counseling room or a private room where you can meet, that these kinds of conversations are not done over the phone. Again, we say this all because this is what we know is best practice, but we know that, of course, COVID made us do very, very difficult things over the phone. So we know that it can be done. It is not ideal. I think it's fairly traumatizing because you can't really sense the nonverbal communication aspects. Connections can be bad. People can be very distracted. Even if you've asked them to go to a quiet space, it can be hard. So yes, it's not a simple answer. It's a yes and no answer. Duncan, do you sometimes find that you have to make difficult phone calls in your setting?
Yes, I was wondering, you may get a case, but now the victim, maybe you requested an investigation, but now the victim is maybe the patient is far, not within, maybe the patient has traveled. Now, I was wondering if you can be able to break that bad news through the phone call.
Yeah, so in those kind of
like
situations, I know, of course, with our communities and our populations that we're taking care of, we know that generally the Somali refugee community they're not always stable, right? It's not part of their culture as well. So I definitely do understand that there might be situations where a patient has left the hospital and you finally get the test results. I would suggest the first option would be, if it is possible for them to come for a meeting to talk about the results. And then again, if that is not possible, then maybe arranging a time, knowing that it's going to be a meeting in which important information is going to be shared. I think if you call and you've kind of taken someone off guard, it might be very difficult. So very similar to how we set up meetings and family meetings with the Spikes model. Like you tell them ahead of time. You don't just go to the bedside and say, I have bad news to tell you. Here's the bad news. And I'm really sorry we couldn't wait for your husband or your spouse to come, but here's the bad news. And do you have any questions? Sort of thing. We don't do that. So even in a situation where you feel like there's no other option other than sharing the information over the phone, maybe you make a first phone call and say, hi, do you remember me? I was working at the health facility and I recently got some of the test results. I would really like to talk to you and your family about this. If they say they can't come in, fine. Then you say, is there another time where we can all discuss this, maybe over a speakerphone, or if it's possible to do WhatsApp video or something like that? Then you prepare them and they can also prepare themselves for what's going to be received. And I think that definitely goes into the preparation and setting up the environment for receiving difficult news. Annalise, I know that you're working in Dadaab. Do you often find yourself delivering bad news over the phone? I know Annalise also does a lot of home visits too. Do you ever have to break bad news over the phone with your patients? No.
I've never.
Okay. Okay, well, I mean, Duncan, if there's very particular situations, sometimes I think the reality is that people, it's a natural instinct to want to avoid these very difficult situations. So if you believe that there's no other option, we of course want people to know what's going on. We don't want to withhold information from people, but yeah, maybe the pre-phone call before you actually have the call where you're sharing the information would be important. We've gone over a little bit. I'm very sorry about that. Does anyone have any final thoughts? Dr. Zippy, are you with us today? Would you want to make any final thoughts to the healthcare workers? Might not be there. There was a few months ago in our previous ECHO course, we also had a communication session, and there were several questions that the participants put out. So I'm going to also share that document. There's some really good information related to breaking bad news. Sometimes it does become an ethical decision. It isn't easy. So we will share this around, and thank you everyone for joining today. Thank you, Vilma and Sarah, for an engaging session and really bringing some really interesting thoughts out, especially related to using translators and now even this thing of breaking bad news over the phone. I know you all are very busy, but thank you for taking this time out of your day. If you can fill out a short feedback form if you're listening to us over on the computer, shoot to our admin support from Project ECHO shared the link, but I can also share it with you again. Yeah, and our faculty have all agreed to be part of the team for the next few weeks. So if you have questions, just email me and let me know, and we can pass it along. Thanks, everyone. Next week, we will meet again at the same time, 3 o'clock East Africa time on May 25th, and we'll be talking about self-care and how to ensure that you don't burn out, and different ways you can also think about that related to palliative care work. Thanks, everyone. Thanks, Gabriel. Thanks, Duncan.
Bye.
Thanks for joining us. We'll see you guys next week. Thanks, Annalise. Sorry you're so busy. Annalise is one of our faculty